الأول أشكر.
لحظة هذا ثانية.
حاضر يا بيه.
بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. Welcome everyone to this new meeting of Egyptian Society of Nephrology and Transplantation, CME meetings. Back to our activities after our very big Congress, 14th ESNT Congress that was in the previous month. Hopefully that you enjoyed all this marvelous Congress. Today we will start by a very important lecture of my colleague Al-Qasr Al-Aini and my brother Professor Ahmed Fayed, who is the Associate Professor of Nephrology and Internal Medicine, Cairo University. Professor Ahmed was graduated and from Qasr Al-Aini, received his master's thesis and MD from the same faculty, and starting from his residency forwards, he is working in nephrology department of Qasr Al-Aini Hospital and also in medical intensive care unit. We had a long journey together in establishing critical care nephrology specialty both in Qasr Al-Aini and in Egypt through our many critical care nephrology conferences, Qasr Al-Aini critical care nephrology conferences, 6 conferences, and AKI courses. Also, Professor Ahmed has many national and international publications, the last of which was about 1 week ago. It was a multi-center study about the relapse of HCV cryoglobulinemia after direct antiviral treatment. We hope for Professor Ahmed many progress, and we are expecting to enjoy this talk today. He will speak today about cystic kidney disease, and I think from the title that you can see from the shared slide that he is going to speak in a clinical based approach. He is speaking about an approach to cystic kidney disease. Please, Professor Ahmed, start, and we'll leave the questions till the end. Thank you. Start, please.
Thanks, my dear brother and dear colleagues, Dr. Yasser Abdelhamid, Professor of Internal Medicine and Nephrology in Qasr Al-Aini, Cairo University. We will talk today on simple approach to how to approach the cystic kidney disease. We have the 2 parts in the lecture. The first part, which is our approach about the cystic kidney disease, and the second part in the lecture, we will present a real life case presentation. This is our agenda, which includes an introduction, and then we talk about the epidemiology of the cystic kidney disease and what is the characteristic of the cystic kidney diseases, and how to clinical assessment of the patient with the cystic kidney disease, and what is the roadmap for the cystic kidney disease approach, and how we treat the different cystic kidney disease. First is the cystic kidney disease. Cysts, which are an epithelium-lined cavity that filled with the fluid, and the renal cysts are clinically insignificant or may cause an end-stage renal failure and develop due to genetic or non-genetic causes, either in the children or and adults. And the cystic kidney disease may be the part of the multi-system disorder with extra-renal symptoms, and the most common cystic kidney disease in adult is autosomal dominant polycystic kidney disease. The cystic kidney disease is diagnosed mainly by the renal size and the cyst localization, as well as an extra-renal symptoms. Now, the advances in the molecular genetics has encouraged the attempts to unify the diverse spectrum of this cystic kidney disease under the pathophysiological concept of ciliopathies. This is the new term of cystic kidney disease. And what is meant by the cilia? Cilia are the small hair-like cellular organelles that is present in almost all vertebrate cells. And when to go to by sensing this cilia, by sensing the extracellular signal and transferring them to the interior of the cell, and the cilia so regulates the function such as cellular proliferation, differentiation, epithelial cell, and the cell polarity and the nerve growth and the tissue maintenance. And the cystic kidney disease here, which is developed due to the several etiology, mainly due to the defect on the cilia, but there is a wide spectrum, including developmental cause, inherited cause, acquired cause, and the systemic disease related. And this is the molecular structure of the cilia or the cilia centromere. Either here is the defect in the receptor, either in the polycycline 1 or polycycline 2, due to the polycystic kidney disease 1 or 2 genes that develops the adult the autosomal dominant polycystic kidney disease, or in the PKHD1 we develop the autosomal recessive polycystic kidney disease. If the defect in the transition zone, it will produce what is meant by the nephronophthisis that will we prescribe later. And also the defects may be in the basal body or in the transcription factor. This will develop the different ciliopathy syndrome that will be prescribed simply in the brief way now. So that any abnormality of the cilia centrosome complex resulting into ciliopathy and ending to cyst formation. The degree and the severity of this gene mutation and whatever the mutation occurred at either the morphogenetic stage or in the maintenance stage, this will be determined the severity and the time of onset of the disease. So that the severity of the disease and the time either it appears in the childhood, in the adolescence, or in the adult stage will develop either this degree of gene mutation developed during either the morphogenetic stage early or in the maintenance stage, which is occur late. What is the non-genetic cystic kidney disease? The non-genetic cystic kidney disease, it may be developmental or acquired. The developmental, which is the medullary cystic kidney disease, or what is meant by medullary sponge kidney, or the renal cystic dysplasia, which include multicystic dysplasia, or the cystic dysplasia that is associated with the lower urinary tract infection, or the diffuse cystic dysplasia, which either be one of the syndrome or the non-syndromal. And the acquired, which is the simple cyst, either solitary multilocular cyst, and what is meant by hypokalemic cystic disease, and the acquired cystic disease in the advanced renal failure. And the other issue, which is the genetic cystic disease, which is either autosomal dominant, like the autosomal dominant polycystic kidney disease, and the tuberous sclerosis complex, and the von Hippel-Lindau syndrome, and also the autosomal recessive, including autosomal recessive polycystic kidney disease, or nephronophthisis, or the Meckel-Guprar syndrome. And the X-linkage is the orofacial digital syndrome type 1. Simply, we will present the acquired cystic kidney disease. One of them is either the hilar cyst or the hypokalemic cystic disease. The hypokalemic cystic disease, which is the renal cyst that are often seen in association with the chronic hypokalemia and secondary to primary hyperaldosteronism or other renal potassium wasting disorder. And the hilar cysts are spherically accumulation of the clear fat droplet containing fluid within the renal sinuses. And this cystic structure, which is the hilar cyst, these are not lined by the epithelium like the typical cystic disease, and the most commonly seen in the debilitated patient, and this may represent as an atrophy of the renal sinus fat rather than the true cyst, because we are agree that the cyst is lined by the epithelium, but this hilar cyst, it is not lined by the epithelium. The other two acquired cysts, either the perinephric pseudocyst, which is typically occurs under the renal capsule or in the perirenal fascia. And this occurs as the result of the urine extravasation from the traumatic or the spontaneous rupture of the renal cyst, or as the posterior extension of the pancreatic pseudocyst. This is not the true cyst. This is called perinephric pseudocyst, which is one of the acquired cystic kidney disease. And the acquired cystic kidney disease in the renal failure, which is occurring in our patients on the maintenance hemodialysis due to the results of the progressive structural end-stage kidney remodeling, and they may be associated with high risk of the renal cell carcinoma. So as you see, the issue is very complex. We will go to the epidemiology of the cystic kidney disease. Let of us know that the incidence of other autosomal dominant polycystic kidney disease, which is the most common cystic kidney disease, it occurs in 1 to 500 to 1,000 person, which affects 12.5 million person worldwide, and this is mostly present in the adults. And the end-stage renal disease is one of the significant complications of the autosomal dominant polycystic kidney disease, and the symptomatic progression is seen mostly in men. And autosomal dominant polycystic kidney disease affect all racial and ethnic groups equally. When to go to the incidence of autosomal recessive polycystic kidney disease, the incidence is low. It is 1 in 6,000 to 550,000 newborn. And it is mostly diagnosed here in the infancy. This is developed early in the morphogenetic stage, not in the maintenance stage or the adolescence. And it is the cause of 5% of end-stage renal disease in the children. And what is go to the other cystic disease, which is an incidence of juvenile nephronophthisis, which occurs in 1 in 5,000 persons. 10 to 20% of the children with this condition present with the chronic renal failure, and 1 to 5% of the all patients of this needs dialysis or transplantation. And additionally, this juvenile nephronophthisis is the most common reason of the genetic end-stage renal disease in the children. And the other issue, which is one of the autosomal inheritance, which is the tuberous sclerosis complex, which occurs in 1 in 10,000 to 50,000 person, and represents 20 to the 25% of these patients, and they have renal cysts. And this diagram represents the age distribution of the different cystic kidney disease. Here, the autosomal dominant, which presents more in the adults, but maybe start in the neonates. And this is the autosomal recessive, which appears mainly is the disease of the infants and neonates. And the nephronophthisis appears in the infants, adolescents, and the adults. All are the same. And the medullary cystic kidney disease, this occurs here in the adults. And the tuberous sclerosis complex start in the neonate and decrease with the age. And the von Hippel-Lindau disease start in the late adolescents and the adults. And the simple cyst occurs mainly in the late adolescence, but more common in the adults. What is the characteristic of this different cystic kidney disease? Simply the autosomal dominant polycystic kidney disease, which is the most common one. What is the genetic basis? All of us know it is the mutation either in the PKD1 or PKD2, which is accounted to more than 90% of all cases. And the renal manifestations of this mainly is the urine concentration defect and enlarged kidney with continuous growth of the cyst throughout, and hematuria, hypertension, and decline of the GFR with advancing age. And what is the extrarenal manifestation? Is the presence of the liver and the pancreatic cyst and the intracranial aneurysm, which is very important, and we will highlight this and when to screen of the intracranial aneurysm. The other issue is the arachnoid cyst, abdominal hernias, and the cardiac complication, mainly valve abnormality, mainly mitral or the tricuspid affection, and also left ventricular hypertrophy, and also the hypogonadism leading to the male infertility and intestinal diverticulosis. And lastly, it is maybe associated with the cystic lung disease and bronchiectasis. This is represented as simply what is the molecular basis of the autosomal dominant polycystic kidney disease, and all we know it is the defect in the cilia. Defect here in the polycycline 1 and 2. This leads to the decrease in the intracellular calcium, decrease in the phosphodiesterase. This phosphodiesterase is important to catalyze the cyclic AMP to the AMP, so that there is marked increase in the cyclic AMP. In addition to this, with the vasopressin 2 receptors, here the adenyl cyclic AMP and leads to the marked activation of the cyclic AMP, which activated the protein kinase activity with the activation of the mTOR and the mitogenic activated protein kinase, and this leads to the proliferation and the cyst formation. And this molecular diagnosis is important because if we target by the vasopressin receptor here, which you put here, so that if we put here the cyclic, we may be the mTOR inhibitor, as we will discuss in the treatment. And the renal manifestation of the adult polycystic kidney disease flow and the pain, which is very important, caused by either hemorrhage in the cyst, gross hematuria, nephrolysis and stone formation, and hypertension is organ damage. The hypertension and this simple diagram, what is called by the Raven criteria for ultrasonographic criteria for diagnosis of the adult autosomal dominant polycystic kidney disease. We have the two arms here. What is the positive family history, and the other issue is the negative family history. With the less than the 30 year, we need the 2 cysts bilaterally or unilaterally. And the negative family history, 5-6 cysts bilaterally is needed for diagnosis. And the 30 to 60 years, 4 cysts bilateral, but here is 5 cysts bilateral again. And the more than 60, 8 cysts bilaterally, and here is 8 cysts bilaterally. This is what is meant by the Raven criteria for ultrasonographic for diagnosis of the adult polycystic kidney disease. One of the important manifestations of the extrarenal is the intracranial aneurysm. And this intracranial aneurysm here may be the unruptured or ruptured. The ruptured leads to what is meant by the headache, neck stiffness, low back pain, and maybe loss of consciousness, focal neurological deficit, and also it may lead to the vitreous hemorrhage. Mainly it occurs in the periretinal or subhyaloid, and the subhyaloid here is the hemorrhage under the lens direct. And the unruptured, it is maybe asymptomatic, which is incidentally discovered, or symptomatics presented with cranial nerve compression, any cranial nerve according to the site of the aneurysm, compression of the other CNS structure, and they may be present with the distal embolization leading to transient ischemic attack, seizure, and headache. So that is very important to what is the indication to screen for intracranial aneurysm in the patients with adult polycystic kidney disease, mainly before the major elective surgery for this patient, or the presence of the central nervous system manifestation, whatever is, or if there is a family history of intracranial aneurysm, or the high risk occupation for this patient, like the airline pilot, and the new onsets of the severe headache in the patients with the autosomal dominant is an indication for searching for this intracranial aneurysm. The other cystic kidney disease, which is the autosomal recessive. Genetic base is the mutation of the PKHD1, and the renal manifestation mainly is the chronic renal insufficiency and multiple renal cysts. And the extrarenal here is associated, there is the concomitant affection of this mutation in this gene with the biliary system development, so that the patients here will have the biliary dysgenesis and present with hepatosplenomegaly and the congenital hepatic fibrosis, and the hepatic complication is very important, cholangitis or the development of cholangiocarcinoma. And if we go to the nephronocysis, the genetic base, there is the 18 known subtypes accounting for 40% of case, and the products of this gene, as we prescribed, is associated with the disorders that localize the primary in the primary cilia, mainly in the basal body or the centromere of the renal epithelium. The renal manifestation for the different nephronocytes is the same. First is the polydipsia, urine concentration defect and the secondary enuresis in the childhood, and the polyuria, corticomedullary cyst, tubulointerstitial nephropathy, and the tubular basement membrane thickening and the disruption. And when to go to the extrarenal, there is the different extrarenal complication, depend upon the exit syndrome. The first one of them is what is called by senior Lufkin syndrome. And this is the renal manifestation is the same, but the genetic basis here is the defects in the nephronophysis gene 5 and 6, and they may also occur in the other subtype except number 7. And what is the most important extrarenal manifestation of this senior Lufkin syndrome is the retinitis pigmentosa, and this is the real life, which is the fundus examination of the 37 years old patient with night blindness for the past 11 years old. And here there is the presentations of retinal pigment epithelium changes, which are seen here in the fundus examination. And on the other issue, which is the black one, this is what is called by the OCT, or the optical coherence tomography, which represented here by the arrow is the disruption of the ellipsoid zone line of the retinal pigment epithelium. This is a characteristic finding for the senior Lufkin syndrome. And there is another presentation. These patients also of the senior Lufkin syndrome may be present with the situs inversus totalis. And the Joubert syndrome, which is the second one, the renal manifestation again is the same. And the genetic base here is the mutation of any different 21 genes. And the extrarenal manifestations, mainly cerebellar vermis hypoplasia or aplasia, liver fibrosis, and retinitis pigmentosa again, and the globoma of the eye, which is characteristic, or the altered neonatal respiration. This is what is meant by the globoma of the eye. This is the healthy eye, and there is the congenital abnormality of the membrane of the eye presence with the globoma, and this is the real life globoma of the eye for the Joubert syndrome. And again, it is the Mickel-Gruber syndrome, with the genetic base is the mutation of the 11 different genes. And again, the renal manifestation is the same for all nephronophysis. And the extrarenal, mainly bilateral post-axial hexadactyly and the hepatobiliary ductal dysgenesis causing fibrocytic liver disease and CMS malformation, usually occipital encephalocele. And when to go to the one of the autosomal affections, which is the Bradel-Bett syndromes, here there is the mutations in the Bradel-Bett 1 to 19, which is accounted to 80% of the case. The renal manifestation in the same, and again the difference in the extrarenal, mainly juvenile obesity, mainly polydactyly, and mainly mental retardation, retinal defect, anosmia, and also hypogonadism with male infertility. And this is the picture for hexadactyly in the adult patient with the Bradel-Bett syndrome. And when to go to one of the commonest, which is the medullary cystic kidney disease, which is this one, it is not up to the dates, don't have extrarenal manifestation. The genetic base, it is either type 1 or type 2. Type 1 is the mutation of the MUC1 mutation, which is associated with type 2, or MUC-OD1, which is accounted to 70.8% of the type 2 disease. And this is the medullary cystic kidney disease, which is characterized mainly by dilated medullary and the papillary collecting duct, which giving the renal medulla the spongy appearance. Here the name of the medullary sponge kidney instead of the medullary cystic kidney disease. And it is associated with mainly nephrocalcinosis and the recurrent calcium nephronolysis and abnormality in the renal acidification and urine concentration. And also this leads to bone mineralization defect and increasing the risk of the urinary tract infection. And this is picture simplify what I say. This is the kidney and the cystic abnormality with the characteristic with the difference optic, skeletal, liver, cardiovascular, either developmental or reproductive, and the muscular, CNS, endocrine, and the facial. And each one here is coding with the different either autosomal cystic kidney disease, either Joubert syndrome, or either the medullary cystic kidney disease or Mickel's disease. And when to go to the other issue, which is one of the complex syndrome, is called the von Hippel-Lindau syndrome, which is an autosomal dominant mutation in the von Hippel-Lindau. And the renal manifestation is mainly multiple renal cysts resembling the autosomal dominant and renal cell carcinoma. And the extra-renal manifestation here is mainly hemangioblastoma in the CNS, mainly in the retina, brain, and spinal cord, and the possible pheochromocytoma, pancreatic cyst, pancreatic and neuroendocrine tumor, and endolymphatic sac tumor of the inner ear, and also the other cystadenoma of the epididymis and the broad ligament. And this is the classification of the von Hippel-Lindau, which is the type 1 or type 2, A, B, or C. Type 1 mainly is the predominantly hemangioblastoma and renal cell carcinoma, with the low risk for the pheochromocytoma. And type 2A, what is the difference? Hemangioblastoma and the pheochromocytoma is the main, but there is a low risk for the renal cell carcinoma. And the type 2B is the difference is the hemangioblastoma with renal cell carcinoma and the pheochromocytoma, which is the high one. And the type 2C, this is mainly predominantly presented with pheochromocytoma and the very limited risk for hemangioblastoma and renal cell carcinoma. This is how to differentiate between the classification of the von Hippel-Lindau subtypes. When to go to the tuberous sclerosis complex, the genetic backgrounds mainly is the sporadic with the tuberous sclerosis complex 1 or 2 germline mutation, and the renal manifestation mainly here is the renal cell carcinoma and the angiomyolipoma. Sometimes there may be multiple renal cysts. And the extra-renal cyst manifestation mainly hypomyelinatic macules, epilepsy, cognitive dysfunction, behavior disturbance, and developmental disorders. And this is the issue for the patients with the tuberous sclerosis complex, and this is the major feature. There is the facial angiofibroma, and this is all the major feature, and this is the minor feature that is the presence, as we see here, the lymphangioliomyomatosis that is the presence here, and also the multiple renal nodular hamartoma, which is the present here, and the non-traumatic urological periangial fibroma and the hypomyelinatic macule, and they want to go the multiple pits or the hamartoma of the gastrointestinal tract, the bone cyst, and the retinal complication. And the multiple renal cyst here is one of the minor complication, but the renal angiomyolipoma is one of the major criteria. To diagnose, we need the definite tuberous sclerosis, 2 of this major feature, and one major and the 2 minor feature. This is the definite tuberous sclerosis complex. When we have 1 major and 1 minor feature, this is indicate probable tuberous sclerosis complex. But when we have 1 major feature only or 2 minor feature only, this is indicate as the possible tuberous sclerosis complex. And which is now is a very important issue to simplify what we say, how to do the clinical assessment of the patient with the cystic kidney disease. First of all, we talk about the genetic testing. Genetic testing, it is not done at the part of the standard care. Genetic testing is helpful to assess the potential living related kidney donor with negative or equivocal scan to detect also the rare form of the cystic kidney disease that will be prescribed. And the gradual expansion of the renal cystic disease can be measured by what is meant by total kidney volume, and this part we will be discussed in details how we assess. Because the measurements of this TKV or the total kidney volume is a valuable biomarker for the treatment effect and the more sensitive in the disease progression than the GFR and the serum creatinine in this patient. This is simply the roadmap. The roadmap test for bilateral renal cyst. When we have the presence of the bilateral renal cyst, yes. Is there the presence of the solid tumor or not? This is the second question to ask it. If yes, if the presence of angiomyolipoma, so that we diagnose the tuberous sclerosis complex by the clinical criteria and they may be confirming by the genetic test. But if we have the renal cell carcinoma, it may be the tuberous sclerosis complex or von Hippel-Lindau disease, which is confirming by the other clinical setting and genetic test. And if we have no solid tumor, we must to connect on the kidney size. If the kidney size is normal or small, normal and small and the presence of bilateral linear cyst and the localization of the cyst. If the localization of the cyst, we can localize the cyst in the corticomedullary, either it is an autosomal recessive or autosomal dominant. The autosomal recessive here with the localized cyst in the corticomedullary, we are dealing with the nephronophthisis. With the autosomal dominant here, we are dealing with the medullary cystic kidney disease. But if the localization of the cyst, but this is the ubiquitous, or it is the multiple cyst bilateral, so that, and they have the kidney is enlarged, we must to look for the liver. If there is the presence of the liver fibrosis, if there is the presence of the biliary dysgenesis, if no, so it is an autosomal dominant, so that's the autosomal dominant polycystic kidney disease. If the liver fibrosis is present and the autosomal recessive polycystic kidney disease is present. And here we wanted to go to how to differentiate between the different nephronophthisis. We will go to here to the extrarenal manifestation. If we are dealing with polydactyly, juvenile obesity, intellectual disability, anosmia, and retinitis pigmentosa, here we are most probably we are dealing with the Prader-Willi syndrome. But if we are going to deal with cerebellar vermis, hyperplasia and aplasia, retinitis pigmentosa, liver fibrosis, and the presence of the glaucoma of the eye, we are dealing with Joubret's syndrome. And when we present only the retinitis pigmentosa is the presence, we are dealing with senior Lofgren syndrome. And when we are dealing with bilateral hexadactyly, fibrocystic liver disease, CMS malformation, we are dealing with Mickel-Gruber syndrome. The diagnosis of adult autosomal dominant polycystic kidney disease is clinical. However, the genetic analysis sonographic used for early detection of the patients who are asymptomatic and they have family history, and we discussed previously the Raven criteria for the diagnosis. The sonograph is the standard cost-effective imaging method, but CT and the MRI are more prognostic methods. We will now present some of the features for the real-life features. This is an axial and coronal CT imaging of patients with autosomal dominant polycystic kidney disease with multiple renal cysts, as you see. And this is another axial and coronal T-weighted MRI scans of the patients with advanced autosomal dominant polycystic kidney disease. When you go to the yellow arrow, this is the cyst in the renal cyst here. That is the presence with the yellow arrow. And when to go to the white arrow, this is the hepatic cyst that is the presence here. And when you go to this white arrowhead, this is an hemorrhage of one renal cyst is hemorrhagic. The total kidney volume, which is one of the very important and one of the messages that will be needed to be delivered through this lecture. The total kidney volume is a strong predictor of the future renal insufficiency in cystic kidney disease. Different imaging modality, ultrasound, MRI, and CT scan, and the post-processing method, stereology, and ellipsoid calculation are important to determine the total kidney volume. The first step is determine the total kidney volume by determining the right and the left. This is a mathematical issue by deriving the length, widths, and depths. This is the length, widths, and depths. This is the length width. How we calculate the length? The length is obtained by the average maximum longitudinal diameter taken from the coronal and sagittal image, or maybe the single longitudinal diameter that will be taken in the measurements that is obtained here in the coronal image, as we see in the image. And the widths and the depth is usually of the kidney obtained from the transverse image with the maximum transverse diameter. And after we obtain this, we have the height adjusted total kidney volume, which can be seen as the annual kidney growth and the risk for end-stage glomerular filtration rate decline. This is the second step. After we calculate the total kidney volume, we multiply over the height, we obtain the height total kidney volume, which is plotted against this diagram to classify the patients either class 1A with class 1B, class 1C, class 1D, and class 1E. The class 1 is the less than 5% estimated kidney growth failure with the low risk, and when we go up to the E, which is the high risk. The total kidney volume is a very important prognostic factor for the progression of the patient with the autosomal dominant polycystic kidney disease. Again, we emphasize that the molecular genetic base, it is not done as the routine standard care, and it have the play, but it play a major important role in the patient predicting the disease progression, which may be as a piece of puzzle for making a therapeutic decision in the future. And the current and evolving, what is the current and evolving indication to do this genetic test in autosomal dominant polycystic kidney disease? We have the two scenarios. First scenario, where the genetic test is indicated, suspected autosomal dominant with no apparent family history or with equivocal renal imaging, or autosomal dominant kidney disease in young patient less than 25 years, because the Riven criteria starting from 30 at the risk subject. What is the risk subject? The living related kidney donation evaluation and obtaining life or disability insurance. And the other issue is the prenatal and the pre-implantation genetic diagnosis. Scenario, the other scenario, which is the indication for the genetic testing to identify the high risk patient for the novel disease modifier therapy or the clinical trial, or to delineating the cause of the atypical clinical presentation as early and severe disease, and discrepancy between the imaging finding and the marked deterioration in the renal function, asymptomatic unilateral segmental cystic kidney disease, or marked intrafamilial disease discordance, or suspected somatic mosaicism syndromic form of polycystic kidney disease, which that is present in the nephronophthisis. This is the genetic testing for all cystic kidney disease and the genetic base analysis that is will be present. I want to go to the another, which is an autosomal recessive polycystic kidney disease, which is diagnosed by genetic testing here and the sonography. Serum sodium concentration may be useful for evaluating the hyponatremia in these patients, and urine osmolarity for disabling reduce the concentration ability. Again, we must look for the liver, because the biliary dysgenesis, bilirubin and the hepatic enzyme CBC perform for the risk for patient for portal hypertension and splenic dysfunction. And again, this is an imaging for autosomal recessive polycystic kidney disease in 4 years old girl with contrast enhanced, and shows that the striated nephrogram and the prolonged corticomedullary differentiation. And this is another issue of the T-weighted image. This is the white arrow for the liver Caroli syndrome with the multiple cyst, and here the white arrowheads here for the polycystic kidney disease in autosomal recessive polycystic kidney disease. And the juvenile nephrolysis and the medullary cystic kidney disease diagnosed by increased serum sodium concentration, maybe minimal proteinuria and normal sediments. Sonographic and CT scan shows a shrunken kidney, and this is an ultrasound scan shows the nephronophthisis, which is an adult patient with the senior Loken syndrome and multiple kidney disease with the small kidney size and multiple renal cyst and increased echogenicity, as you see. And this is the T-weighted image and T1 weighted image brain MRI for patient with Joubert syndrome, which is characteristic by the cerebellar vermis aplasia and the malformed brainstem, which is an indicated here, and giving here the characteristic appearance in the MRI caused the molar tooth sign. And this is X-ray imaging. As I see, the senior looking syndrome, which is characterized by the retinitis pigmentosa. It may have the situs inversus totalis, and there is the situs inversus totalis in patient with nephronophthisis and senior looking syndrome. And this is an axial two-weighted MRI and coronal fat suppression, and the MRI with patient with the tuberous sclerosis complex. Here we will go with the white arrow here for the cystic kidney disease that is present here, and here with the cystic kidney disease. And when you go to this white arrowhead for the bilateral renal angiomyolipoma. And another helpful tools in the cystic kidney disease is what is meant by the Postnick classification, which help to diagnose and manage the cystic kidney disease pre and post contrast scan. It has the 4 category 4 evaluations the cystic kidney disease. Postnick 1, which is the category, it is the benign simple cyst. It is the simple cyst, thin wall with the clear water content without any septa, any calcification or solid component, and they don't require any further evaluation. And the category 2, which is the benign simple cyst, but like the one, but it have few thin wall and the septa and defined calcification. And here for the category 2, the follow-up of these patients is needed to confirm the diagnosis 6 to 12 months later. And what is meant by category 2F? 2F, it is an indeterminate between category 1 and category 2, sorry, and the category 3. And this is have multiple thin septa that is mainly with minimal small thickening with nodular calcification, and here the follow-up is recommended. When we go to the Postnick 3, 40 to 60% these are malignant, 3 and 4, which is coming. This is a multilocular cyst, thick wall, septa, irregular calcification, and the follow-up periodic imaging here is needed. And the category 4, 85 to 100% this is malignant and the large nodular cyst with enhancing solid components and require surgery. And when to apply this Postnick classification, which is also 1, 2, or 2F, with the presence of symptoms, the pain, hypertension, hematuria, infection, or the presence of lump is no. So that periodic follow-up, especially the 2F. And if the presence of these symptoms may needs and the size of the kidney with the total kidney volume more than the 200 millimeter, and the localization here either parapelvic, yes or no. Yes, we may do an aspiration and consider the sclerotherapy or sclerosing agents to collapse this issue. And if the size is less than 200 millimeter and not parapelvic, consider surgery and lab because or robotic surgery either. But when we go the 3 or 4 stage, this is an excisional biopsy, either cystectomy or nephron sparing surgery or radical nephrectomy may be needed because the risk of malignancy. And in the clinical assessment for this cystic kidney disease, we must put the differential diagnosis because some disease may have the renal cyst in the similar presentation that includes the multilocular cystic nephroma, hemangioma, angiomyolipoma, and also the renal cell carcinoma. So that complete history, physical examination, and the secondary finding with the imaging modality and the genetic testing helpful to differentiate the etiology of this renal cyst. And finally, the treatment, and sorry for the enlargement for the lecture, the treatment of the cystic kidney disease. Cystic kidney disease, it includes the several treatable and the preventable complications such as hypertension, infection, and pain. In autosomal dominant polycystic kidney disease, which is the commonest one, the recommendation to drink 1 to 2 liters per day minimum, and the sodium restriction with exercise and weight control. And hypertension is a common finding, as we see, due to the many causes in the, as we previously mentioned. And there is several options to control this hypertension, either with ACE, ARBs, or calcium channel blocker. And this is the basic phenomena to control the blood pressure. The goal here in if the patients between 18 to 50, 110 to 75, and the estimated GFR more than 60. Otherwise, patients more than 50 and less than 80, estimated GFR less than 60, we target 130 over mean to be less than the 280 millismol by enhancing hydration and spread out over 24 hours, as we mentioned, and the low osmolar take with moderate sodium intake, moderate protein intake, and maintain the serum bicarbonate is very important, more than the 22 milli equivalent, and the moderate dietary phosphorus intake, very important, 800 milligram per day. Moderation of the caloric intake, maintains the normal body mass index and exercise, and the lipid control is important. We start with the low threshold start statin, aiming the LDL to be less than 100 milligram per deciliter. And when to go to the autosomal dominant cystic kidney disease, the tolvaptan. Tolvaptan is the vasopressin receptor antagonist, as we prescribe. When we block this is effective because it will block the adenyl cyclase and will decrease the cyclic AMP, which is the main issue that activate the mitogen activating the protein kinase and leads to the proliferation. But it is given in the selective candidate, and appropriate hydration when you give this drug is very important to prevent stress and hypernatremia. Liver function should be monitored closely during the therapy, and the serum sodium and uric acid mainly require monitoring. And when to use the tolvaptan for progressive patient with the progressive adult polycystic kidney disease, we must to have two indications for this drug to use with the two requirements to meet. The first one is the total kidney volume more than the 75 milliliter, and the total kidney volume increase rate more than 5%, which is the delta change in the total kidney volume. This is the indication when to use this tolvaptan for the prevention for the progressive autosomal dominant polycystic kidney disease. And again, the cyst infection, which can be developed and they can be treated with the course of antibiotics, ciprofloxacin, erythromycin, chloramphenicol, or tetracycline. Renal cyst is generally asymptomatic, but if symptomatic, needle aspiration is needed. And moreover, we may need the laparoscopic surgery for complex cyst. And the autosomal dominant cystic kidney disease, when to do the issue of nephrectomy before the transplantation. If there is a recurrent and severe infection, symptomatic nephrolysis and stone formation, recurrent and or severe bleeding, intractable pain, or may we do the nephrectomy because the suspicion of the kidney cancer and the space restriction. And when we go to the autosomal recessive kidney disease, there is no clinical management specific, only symptomatic treatment, including supportive respiratory therapy for pulmonary insufficiency and the dialysis if the patient develop renal failure, salt restriction and use of antihypertensive for hypertension and low diuretic for edema. And therefore, autosomal recessive kidney disease is the recessive disorder. This is an important deliver message because either parents may be suitable kidney donor for this baby, and in some patients, we must do combine the liver and the kidney because they may be associated biliary dysgenesis. And the indication for the combined kidney and the liver transplantation is the combination of the renal failure and the recurrent cholangitis or significant complication of the portal hypertension, such as recurrent variceal bleeding, refractory ascites, and hepatopulmonary syndrome. This is an indication for kidney liver transplantation. And when we treat what is meant by the juvenile nephronophthisis, and the current treatment is also supportive. And there is some preclinical studies that suggest that the target therapy may have beneficial effect, and the treatment also with the vasopressin receptor antagonist, and requires to attenuate the renal cyst again to inhibit the adenyl cyclase and decrease the cycle AMP and decreasing the progression in the mouse model. And other investigators propose that the therapeutic strategy not targeting the renal cyst, but targeting the renal fibrosis and low dose of the paclitaxel, which has been showing to the promising result, which is an antifibrotic agent in the rodent of renal fibrosis, and again in the real life dialysis or renal transplantation for end-stage renal disease. Medullary cystic kidney disease. Asymptomatic patient require no surgery. Hematuria in the absence of a stone of infection require no intervention. If presence of the tubular ectasia is unilateral and the segmental, we may do the partial nephrectomy because it may elevate the recurrent nephrinolysis and UTI. However, for the majority of the patient, the disease is bilateral, so that medical management is only sufficient. And the very important issue is the hypercalciuria and the nephrocalcinosis, as we said, and the hypocytraturia, which is the predominant factor contributing to the medullary cystic kidney disease related nephrinolysis, so that the mainstay of the treatment is the potassium citrate and the high fluid intake, and the patients with persistent hypercalciuria and or recurrent stone formation may be benefits of the thiazide diuretic. If thiazide diuretics are poorly correlated or contraindicated due to any cause, inorganic phosphate therapy may be used. But to avoid the Sturevite stone formation, oral phosphate shouldn't be used in patients with the previous UTI caused by the urease producing organism, and the patients who are recurrently formed and the pus stone may require lithotripsy and the surgical intervention. Tuberous sclerosis complex, first we talk the angiomyolipoma. Renal angiomyolipoma are generally benign and require no treatment, but the larger angiomyolipoma may develop frequent microscopic and macroscopic hematuria, and the risk of the serious hemorrhage correlate with the aneurysm over than 5 centimeters. Therefore, the disease, this larger angiomyolipoma require preemptive treatment either by nephron spacing surgery or embolization. Recent in the tuberous sclerosis, the International Tuberous Sclerosis Complex guideline recommends the use of the mTOR inhibitor because it will reduce the cyst size and the proliferation by inhibiting the mTOR and the mitogen activating protein kinase as the first line therapy for the treatment of asymptomatic patient growing angiomyolipoma more than the 3 centimeters in diameter. This is the indication as the first line therapy, and the sirolimus and the everolimus also are effective in reducing angiomyolipoma. And the mainstay for the tuberous sclerosis complex associated renal cystic disease is strict blood pressure control. Surgical decompression of the cystic disease have been suggested, but no significant beneficial effect have been stated. The renal cell carcinoma should be suspected in any enlarging fat-poor lesion or when there is the intramural calcification are detected and present, and they should be confirmed by the biopsy because the renal cell carcinoma are frequently bilateral. Renal spacing surgery or nephron sparing surgery should be done performed whatever possible. And when to go to the von Hippel-Lindau, the other one and the last one, surgery continue to be the mainstay in the treatment for the renal cell carcinoma, and optimal management surgical intervention before early surgical intervention before the renal vein invasion and the distant metastasis occur, because metastatic lesion respond poorly to chemotherapy and radiation. Nephron sparing surgery is the procedure of choice, and repeated surgical intervention may be required as the tumor continue to develop, and the bilateral nephrectomy and renal transplantation may be acceptable alternative to the repeated nephron sparing surgery in patients with von Hippel disease associated renal cell carcinoma. But it remains determined whatever the post-transplant immunosuppression may enhance the retinal and the CNS hemangioblastoma, which is one of the major criteria from von Hippel-Lindau and the other lesion found in the patient. This is undetermined issue till now. And the drug that inhibit also the vascular endothelial growth factor pathway, hypoxia inducible factor, and the von Hippel-Lindau, such as the multiple tyrosine kinase inhibitor, such as the sutinab or the sorafenib and the pozapinab, and the other monoclonal antivascular antibody is the bezumab may be used and proven to have the sporadic renal cell carcinoma may be therapeutically useful for this hemangioblastoma and renal cell carcinoma. When to go to the simple renal cyst, how to manage? This is associated either with pain or renal dependent hypertension, managed by percutaneous aspiration under radiographic guidance and the installation of the sclerosing agent into the cystic cavity, or we may do the laparoscopic or marsupialization. What is marsupialization? It is the retroperitoneoscoping cyst unroofing, which may be needed for large cyst containing volume more than 100, and the cyst infection with the Enterobacteriaceae, Staphylococci, and the Proteus may be reported, and the operative and the percutaneous drainage is often required in addition to the antibiotic treatment. And this is one how to deal with the simple renal cyst, which is the symptomatic and the intractable size. Attempt for the percutaneous drainage, which is the maximum 2 times to fill the attempt for percutaneous drainage. Position of the cyst making the percutaneous access unsuitable, or reaccumulation of the cyst, largely go to the laparoscopic excision or the roofing of the cyst with marsupialization. If still unable to excise or deroof, open surgery and excise or deroof the surgery. And the take-home message finally, and sorry for the long discussion, the cystic kidney disease are multi-system disorders that is present with the definite extrarenal manifestation, and it is regarded as the ciliopathy, and this is the ciliopathy with the different change in that is occur in the cilia centromere, and the most prevalent again is the autosomal dominant polycystic kidney disease, and the diagnosis of the cystic kidney disease requires through clinical workup, taking not only the kidney size and cyst localization, but don't forget the extrarenal manifestation, and again the utility of the genetic testing vary greatly between the disease. However, testing is generally needed in the cystic kidney disease accompanied with the renal tumor, and this is the extrarenal manifestation of the different cystic kidney disease. And this is our roadmap for the bilateral cystic kidney disease, and thank you. This is the first part of my lecture.
Thank you, Professor Ahmed, for this very elegant talk illustrating various parts of kidney cystic disease. Do you have a case for discussion?
Yes, we have the simple case from the real life case, Dr. Yasser, from Qasr Al Aini, to deliver also an important message for our colleague.
Okay, we can go through, but let me summarize your talk that you illustrated the various types of kidney cystic lesions. These are mainly ciliary disorders, and either developmental, genetic, or acquired, or containing a part of secondary to systemic diseases. Also, you illustrated how to differentiate between various types of the disease depending mainly on the presence of tumor or not, presence of kidney size, liver affection, and denoting the importance of extrarenal manifestations in differentiating various types of syndromes. Also, genetic testing, which is difficult to be done and is not recommended in every case, but is recommended in certain cases as pre-transplant situations, in cases of tumors, and in certain conditions of other polycystic kidney disease. Or I think you have illustrated the importance of total kidney volume in predicting the progression to renal insufficiency and to predict how much about the prognosis. Also, the nature of the cyst in the Bosniak classification, depending on the size and the criteria, radiological criteria of the cyst, and the importance of combining the symptoms and the size of this in this classification to reach the proper diagnosis, and how much this cyst is risky to form malignancy. And they went through the treatment, many different forms and many different treatment, which is generally maybe follow-up, maybe surgical treatment, and the importance of follow-up to detect tumors in certain diseases. And this illustrates the importance to know the nature of the disease. What is the incidence of tumor, renal cell carcinoma or other tumors, to follow up. Medically, the importance of tolvaptan in other polycystic kidney disease, mTOR inhibitors, and reducing the progression, and many other methods of treatment. Mainly, you summarized in your last slides what you said in all previous slides clearly, and thank you very much. We have one question in the chat before we go through your case from Rami Shahat. What about genetic therapy for adult polycystic kidney disease?
واحنا جاوبنا Torias, this we answers on these questions during our lecture, because we have the two different scenarios. The diagnosis is mainly clinical by the autosomal dominant polycystic kidney disease, but we pass to the genetic test is the presence with the atypical presentation, either the early presentation or negative family history, or the definite criteria or the Raven criteria. It is not for the polycystic kidney disease. This is an indication. Or if the patients have the equivocal imaging size, if it is not clear, we will do the genetic testing. But the genetic testing, I emphasize that it is not done with the routine standard care for the autosomal dominant kidney disease. It is done only for the patient, for screening for liver, for the kidney donation, and also for the cystic kidney disease, mainly associated with the extrarenal manifestation and the tumors.
I think this is an important message to highlight, that it is not the solution, and it is what will not get the final solution for differentiating these cases. In certain cases, only recommend genetic testing. Professor Saeed Khamis wants to comment. Welcome, Professor Saeed, and welcome back.
Thank you, Professor Yasser. Thank you, Professor Ahmed, for this elegant presentation. Actually, Professor Ahmed didn't leave any point to comment, but it was very comprehensive and panoramic presentation, actually. One comment only regarding the acquired cystic disease of the kidney in end-stage disease patient. Usually, these patients, as Professor Ahmed said, on dialysis for longer period, almost 3 to 5 years on dialysis. And these patients, usually we detect them, or we predict that most of them, they don't need ESA or iron for their anemia treatment. I mean, their hemoglobin start to improve spontaneously or naturally. Not all of them, but most of them. My question to Professor Ahmed, do we need screening for this acquired cystic disease of the kidney, as because it is predisposing to renal cell carcinoma or squamous cell carcinoma especially? And if yes, how frequent, and what is the optimum imaging modality to screen with? Thank you so much.
Thanks, Dr. Saeed, for your comment. First, for the acquired cystic kidney disease that is related to the renal failure, it is indicated for the screening for the renal cell carcinoma if the cyst have the changes that is indicating for the malignancy. Mainly the presence of the mular calcification or the nodular calcification, or with the thick wall that is the present. This is highly suspected for renal cell carcinoma. And when we do this schedule follow-up every 6 months for this patient. If the total kidney volume and the TKV again is changing and enlarged and put it against the chart, we may do the further intervention, because this may progress to the renal cell carcinoma. We deal with this cyst as the cyst with the solid tumor mass. If there is a finding in the cyst suggestive for the tumor, which is taking either Bosniak class 3 or Bosniak class 4, but if the Bosniak is 2F, which is indeterminate, that is the present between that every 3 to 6 months that is needed, because it is not the malignant.
So the modality is CT, not ultrasound.
The modality, Dr. Saeed, ultrasound is the gold standard, but the very important thing to follow up this patient as the prognostic evidence and the imaging issue is the CT and MRI.
Okay, thank you, Prof. Thank you so much.
Dr. Saeed.
Thank you, Professor Saeed. This led me to my question. MRI should usually done with contrast in the view of renal impairment that may be usually present with these cases, such as tuberous sclerosis, for example.
Yes.
Should be done with contrast.
Yes, yes.
Without contrast is not beneficial at all.
It is not beneficial. Yes, Dr. Yes.
Okay. About question about the use of how to prescribe tolvaptan in adult polycystic kidney disease?
To prescribe
tolvaptan.
Yes, tolvaptan, it is given in the selected patient for the patients with adult polycystic kidney disease. When we give tolvaptan, either for two issues. The first issue to decline the progression of the adult polycystic kidney disease, and this is indicated with the total kidney volume more than the 750, or changing in the total kidney volume more than delta changes change every 6 months, more than the 5%. This is an indication for the progression, for the prevention of the tolvaptan. The tolvaptan, when given, there is some important issue. The adequate hydration is very important to avoid the sodium disorder and the dysnatremia that is present for this patient, and we give it for the regular follow-up for the serum uric acid is very important in this patient.
And these side effects makes it not very suitable in all clinical situations.
Yes, it is done here, Dr. Yasser, in the selected cases that we give.
And we can replace by heavy fluid intake.
Yes, adequate hydration is the baseline to decrease the urinary concentration osmolarity to be less than 280.
Okay, the last question is the use of genetic therapy. Is there any role for use of genetic therapy in adult polycystic kidney disease?
This is the trial issue to be used, yes, in the genetic therapy in the different cystic kidney disease after we do, and this is the puzzle that is done for the molecular genetic analysis. Yes, there is the under trial for the treatment for genetic trial and the targeting is the polycycline itself, 1 or 2, and the BKD1, but this is all under trial.
Okay, no more questions and no more comments, and you can go through your case.
This case, as we decided with Dr. Yasser, we must to give the case from the real life to deliver an important message to our colleague. We will present a 38 years old male patient. He had an episode, which is a farmer by occupation, and he had an episode of hematuria for 1 year. He had an episode of the gross hematuria for 1 year. And this gross hematuria, which is resolved spontaneously within a week. He was found to have the multiple cystic lesion in both kidney on ultrasonographic and was subsequently diagnosed as autosomal dominant polycystic kidney disease at a community health center. He didn't attend the clinical appointment for regular follow-up. He now come to us at Qasr Al-Aini complaining of nausea, vomiting, and decreased appetite, generalized weakness, breathlessness for 15 days, painless gross hematuria for 3 days. He was having oliguria less than 0.5 milliliter per kilogram per hour for the past 1 week, and he had no significant family history, and the patient has no history of smoking or any chemotherapeutic exposure. The vital signs, the patient's temperature is 36.8 degrees centigrade with the chart ranging from 36.5 to 37, and the respiratory rate is the 36 per minute, and the oxygen saturation is the 94% on the room air, and the blood pressure is 160 over 100 millimeter mercury in the supine and standing, and the pulse was 100 beat per minute regular with average volume equally felt bilateral of no special character, intact peripheral pulsation. Upon examination, he was not in pain, but he was in respiratory distress. And there is marked pallor in the head and neck, and the neck vein are congested, pulsating with systolic collapse. Cardiac examination is normal, and there is a bilateral coarse crepitation in the bilateral basal lung fields that doesn't clear with scuff. And the abdominal examination, no tender, is a non-tender firm lump that was palpable over the left flank region that is moved with respiration, and the extremities and the neurological examination is normal. And when to go to the lymph node examination is normal, musculoskeletal examination is free, and there is bilateral normal fundi. And the blood investigation reveals that there is the deranging blood serum urea 358 milligram per deciliter, creatine 13.8 milligram, and the hemorrhage is 9.4 gram per deciliter. Liver function tests were normal. Ultrasound of the abdomen shows that the bilateral enlarged polycystic kidney with liver cyst and urinary bladder filled with the clots. And this is the abdominal ultrasound case. At this point, our differential diagnosis: hemorrhage within the renal cyst, coincident infection, nephronolysis, or bladder tumor. We do the non-contrast CT scan of the abdomen and the pelvis, which reveal multiple cysts in both kidney and the liver, but there is a urinary bladder mass on the right lateral wall, as seen here with the arrow, with no evidence of extravesical invasion. On cystoscope, there was large clots and small pedunculated bladder mass 1.5 by 0.5 centimeter on the right lateral wall. In the setting of the renal failure with uremia, the patients underwent intermittent hemodialysis regularly, and after the 3 sessions, his breathlessness and the respiratory system is very good, and the generally well-being is improved. And we do the transurethral resection of the bladder mass under general anesthesia, and the perioperatively mitomycin C was instillated intravesical. And our outcome and follow-up: the patients on the maintenance hemodialysis and under regular follow-up in the nephrology and urology department in Qasr Al Aini, Cairo University, and the histopathology of the transurethral resection bladder tumor specimen reveals that low-grade, non-muscle invasive transitional cell carcinoma, and he had no recurrence in the last 6 months. And our take-home message, which will be delivered from this case discussion: hematuria in autosomal dominant polycystic kidney disease, so mostly to be benign, and they should be evaluated with the high index of suspicion to rule out the malignancy. And again, early diagnosis and the treatment can be very helpful in this condition. And thank you.
Thank you, Professor Ahmed, for this case, and highlighting this point of not only depending on the presence of other polycystic kidney disease as the cause of hematuria. We should search for if there is other possible cause and don't rely on this diagnosis only. You said that use of mTOR inhibitors is now the first line of therapy in other polycystic kidney in
the tuberous sclerosis.
In the tuberous sclerosis, and recommend a certain type of mTOR, not the usual we use. That's it?
Yes.
And regarding rapamycin and everolimus, sirolimus and everolimus,
they have the role in the reduction of the angiomyolipoma.
But I think that the results of these mTOR inhibitors were contradictory.
It is not good till now.
Yes. Okay.
And Dr. Yasser, again, we must need to be highlighted in these cases with the tuberous sclerosis complex in all patients. They prescribe in the certain patient. They prescribe in the certain patient in which patient the mainstay is the blood pressure control for this tuberous sclerosis complex. And again,
yes,
they emphasize that they indicated as the first line of patient with the growing angiomyolipoma greater than 3 centimeters in diameter.
This is the message I want really to stress.
Yes, yes, this is a very important message.
It is not the first line of therapy to go with in all cases.
Yes, yes, yes.
But the results that are mainly somewhat not that clear to use these drugs in tuberous sclerosis in certain conditions,
Yes.
as you said.
And there, again, sirolimus and everolimus in reducing the AML in angiomyolipoma, but not the first line therapy. The first line therapy is the Rapalox.
Yes, the other one. Another question. Now, most cases of other polycystic kidney disease is hypertensive. What is the best antihypertensive medication for adult polycystic kidney disease?
You can deal with a case of the cystic kidney disease, the renin, ACE inhibitor, ARBs, or calcium channel blockers. All of them is given for this patient, and to target the blood pressure to be 110 over and to be less than 85. All type ACE, ARBs, and calcium channel blocker can be used, and also the beta blocker. But the selective beta blocker, because this selective beta blocker, like the nevoblol, because it have the nitric oxide productive, which have a vasodilator effect, it is preferred.
Okay, the question was from Dr. Ahmed al-Sheikh, who thanks you a lot for this highly great lecture before starting his question. You illustrated that an important point that we have clear indications for nephrectomy in cases of other polycystic kidney disease pre-transplantation, not in to be the usual practice.
Yes.
That's it. We have a clear indication. With
the clear indication for nephrectomy, it is either is this patient before transplantation, it is not the routine before transplantation. If the patient with the recurrent or the severe infection, severe nephronylysis, recurrent or severe bleeding, intractable pain. If the pain is not, it is one of the last medication before the transplantation. And again, if there is a suspension of cancer, as Dr. Saeed highlighted, it is very important, and they may be noted if there is have the large kidney size with the large cyst, we may need for a space restriction. This is the solid indication before transplantation.
Another important message. Another question from Dr. Ahmed al-Sheikh. If we have a mother who are seeking for donation, but this mother have a simple renal cyst, can she donate for him? Or summarize your talk again.
This simple cyst, if this simple cyst is Bosniak class 1, Bosniak class 1, this is an debate only the Bosniak class 1, not the Bosniak class 2 or the Bosniak class 2F. The Bosniak class 2, which is like the Bosniak class 1, which have the thin wall, and they may be starting of fine calcification, but this may progress later. But only the Bosniak one with the cyst, with the clear water content and thin, which is the single cyst and simple cyst, we will do the aspirations of this cyst before donation. And they may do the sclerosing and the injection for this cyst, and if good, they may donate.
In your illustration of treatment, especially surgical treatment, you said aspiration many times and sclerosing material, and I don't think the results are that so good, and we have seen many complications regarding this aspiration.
Yes.
But you repeated it many times that it's maybe a recommended line of treatment in many cases. But
yes, Dr. Yasser, the attempt for percutaneous drainage only 2, and if there is 2 failed attempt or drainage, it is an indicated for laparoscopic excision. And again, if the position of the cyst making it percutaneous axis is unsuitable for it, it is not indicated for aspiration or ingestion of the cyst. And if we do one and the reaccumulation again of the cystic fluid, we don't do another aspiration. We will do a laparoscopic excision or marsupialization of the cyst.
Okay, thank you for this clear message. That is usually carries many complications, and we saw many patients having complications from this procedure. We have no more comments and no more questions on the chat. Thank you, Professor Ahmed, for this very long journey through kidney cystic disease. You have illustrated clearly types and how to differentiate, how to reach the proper diagnosis, what is the importance to differentiation, and what are the possible risks for each type, and how to follow up to avoid, and when to be safe and to feel safe in dealing with these types of tests. And you went through radiological evaluation and how to evaluate through treatment, illustrated indications clearly for many clear messages in treatment, either surgical treatment, either pre-transplant preparation, either medical treatment. You illustrated clearly many messages. Thank you very much, and excuse me to close. Thank all of our attendees. Thank Professor Saeed Khamis for being with us and for his valuable comments usually. Thank you, Professor Ahmed. Professor Manal Deep Said, thank you, Dr. Ahmed, and thank you, Professor Manal, for being with us also today. Let me close this meeting and announce about the next one, which will be next Wednesday, inshallah, in the same time, 9 p.m. will be dialysate composition and its impact on clinical impact by Professor Yasmin Naga, and by hemodialysis. We speak in hemodialysis next Wednesday, 9 p.m. inshallah. Thank you very much.